Welcome back to Core EM. I'm Brian Gilberti, and today we're joined by our very special guest in all things pediatric, Dr. Ellen Duncan. Great to have you back in the studio, Ellen.
It's great to be back.
So far this year, we've covered septic joints in children, how we approach syncope in kids, but today we're going to crank up the acuity and talk about something that stokes fear in any attending, a critically ill infant brought into your emergency department. And like anything that is complex and requires a lot of System 1 and System 2 thinking, it's best to review and rehearse how we would approach it so we are primed when the time comes.
Yeah, I think this is a really scary situation for all of us, especially since that differential is so broad. Sepsis is, of course, number one on the differential in any critically ill patient, especially an infant who presents in extremis. But there are really a number of other things to consider as well.
Yes, and this is essential. We'll get back to it later on in the episode, but sepsis is such a broad topic in infants because of its heterogeneity and etiology. It can certainly be an episode in and of itself. But can you touch on it with some general principles and how you go about treating and stabilizing these patients?
So even though we're considering severe infection at the top of our differential, we want to maintain a broad differential, and it's useful to have a framework to consider everything that might be going on in the critically ill infant.
Yes, and this is such an important point because a lot of us in our jobs have to retain some broad swaths of knowledge, and on top of that, we have to access that information in difficult situations. So this is where mnemonics are crucial. Now, can you tell us about what you use when these patients come into your emergency department?
So I personally love the MISFITS mnemonic. I'm someone who finds mnemonics useful in general, but I think even if you can't remember all 10 parts, it's a useful framework for approaching this kind of patient. Diving right in, the first T stands for trauma, which can be both accidental and intentional. Non-accidental or intentional trauma is crucial to consider, especially since there may be few to no outward signs of injury. There are also some general anatomic considerations when it comes to trauma. For example, infants have a proportionally larger head and are therefore more prone to high C-spine injuries, and their liver and spleen are less protected when they have abdominal trauma.
Yes, pediatric trauma, it's one of the most difficult and tragic parts of the job, and it takes so many shapes. It is going to be impossible to give general recommendations on how to approach it aside from sticking to another mnemonic, which is the ABCDEs, and not necessarily in that order. Okay, so that's T. Tell us about H.
So H stands for heart. This is one of my favorite categories since there are so many things to consider, but it's a long one. I hope you're ready for more mnemonics.
Hit me.
The one that most people are familiar with are the 5 T's of cyanotic congenital heart disease, which represent the main right-sided ductal-dependent lesions. You can remember these by counting on the fingers of one hand. So one finger represents truncus arteriosus, where you have a single pulmonary and systemic outflow tract. 2 represents transposition of the great arteries. 3 refers to the 3 leaflets of the tricuspid valve in patients with tricuspid atresia. 4 represents the 4 anomalies of tetralogy of Fallot. And 5 is the 5 words of total anomalous pulmonary venous connection, TAPVC, sometimes referred to as TAPVR, where R stands for return. There are a couple of other things that fall into this category too, including severe Epstein's anomaly and pulmonary atresia or stenosis. On the other hand, the left-sided ductal-dependent lesions, where patients are generally gray or pale instead of cyanotic, include things like aortic arch abnormalities like coarctation or interrupted arch, critical aortic stenosis, and hypoplastic left heart syndrome. Although routine prenatal ultrasound will identify most of these patients, patients with coarced or TAPVC are generally not detected prenatally and usually present when that ductus arteriosus is closing. Make sure to do a really thorough physical exam in all of your critically ill infants, including listening for murmurs, assessing for hepatosplenomegaly, feeling for femoral pulses, checking pre- and post-ductal sats, and measuring blood pressures in all 4 extremities. Any patient who's suspected of having a ductal-dependent lesion should be started on alprostadil or prostaglandin as soon as possible. Because alprostadil can cause both apnea and hypotension, you should be prepared to intubate your patient and support their hemodynamics.
Okay, so this is an excellent rundown of critical cardiac conditions that we should keep in mind. And there will be a table in the show notes for us to revisit since this is such a densely packed topic. This is all a great reminder of the complexities behind cyanosis in a child. And I have to admit, Ellen, that it's rare in my shifts on the adult side that we need to consider the 5 T's. And it really highlights that the work on the adult side of the ED and the pediatric side is very similar in some respects, but also can be markedly different. Okay, but I know there's more here.
Yeah, there sure is. The other cardiac causes to consider in patients are things like arrhythmias and myocarditis. So make sure to get an EKG, chest x-ray, and troponin levels.
Okay, so that's T and H. They're done. They're off the list. Let's move on to E.
So the E here stands for endocrine. The most common endocrine emergency in the neonate is going to be your congenital adrenal hyperplasia crisis. These patients generally have poor perfusion and characteristic electrolyte abnormalities, including hyponatremia, hyperkalemia, hypoglycemia, and metabolic acidosis. These patients should be promptly treated with stress dose hydrocortisone.
Absolutely, Ellen. And your comment really underscores the importance of being vigilant when we review our labs to keep an eye out for these patterns that can be consistent with congenital adrenal hyperplasia. When you spot this, prompt administration of hydrocortisone can be life-saving in these scenarios. Okay, now let's move on to M.
So M here stands for metabolic causes. There are a number of metabolic things to consider, which we'll get into in our next letter, but the main consideration here is hypoglycemia, which itself has a really broad differential that includes sepsis, inborn errors, and toxins.
Okay, and now next up, everybody's favorite topic, inborn errors of metabolism.
So this one is really challenging for me. The big players here are organic acidurias, which are characterized by significant anion gap metabolic acidosis, and urea cycle defects with hyperammonemia. Many of these patients will also be hypoglycemic, so the big take-home here for me is to have a low threshold to check a gas and a pneumonia in these patients.
So this is an excellent point here to remember these relatively rare conditions that we encounter more on the boards than in practice, like organic acidurias, urea cycle defects, hyperammonemia, but we have to tailor our workup when we send off our labs if we're going to be catching these. Okay, now let's move on to the next letter.
So the first S stands for sepsis, which based on its prominence in our differential should really be the first, but that would make the acronym a little more difficult to remember. Patients with sepsis can have very non-specific presentation, so it's crucial to draw cultures, initiate antimicrobials, and give fluids as soon as possible. In these patients, I'm giving vancomycin for gram-positive and MRSA coverage, a third-generation cephalosporin or pip/tazo, and then acyclovir for HSV coverage.
And I'm glad that we are emphasizing this on the episode because this is going to be one of the most, if not the most important component of this mnemonic. So it's going to be an S, but with a capital S. Now let's talk about F.
So F here stands for formula, and the key point is really that mixing formula incorrectly can lead to both hypo and hypernatremia. So on both ends of the spectrum, you can have altered mental status, seizures, coma, and death. So management, as you would guess, depends on whether the sodium is high or low. Symptomatic hyponatremia is generally treated with hypertonic saline, and hypernatremia should be treated with fluid resuscitation.
Okay, important distinction here. Hypo, treated with hypertonic saline. Hyper, treated with fluid resuscitation in general. So now we're in the final stretch. A lot of high yield points here so far. What's next?
So the second I stands for intestinal catastrophes, which do not, as many would believe, include the norovirus that is wreaking havoc all across the ED right now. So in intestinal catastrophes, we have malrotation with midgut volvulus, necrotizing enterocolitis, which can actually happen in full-term as well as preterm infants, and Hirschsprung-associated enterocolitis. Older infants with intussusception may have altered mental status only, as opposed to that typical pain alternating with periods of lethargy. These patients will often have bilious emesis or hematemesis, and in any patient you suspect of having an intestinal catastrophe, you should promptly consult pediatric surgery and radiology.
Ellen, a very insightful review of these diagnoses that we should be keeping on our differential, and it underscores the critical nature of recognizing these conditions early. And as you said, we have to involve pediatric surgery and radiology swiftly, which is a stark reminder of how time-sensitive these situations can be. It's also alarming when we think about how varied these presentations can be and highlights the importance of being thorough with our assessments. Okay, 2 more left. Tell us about T.
So T here stands for toxins, which is a really broad category and deserves its own episode. These patients should be getting at least an EKG and blood work, and make sure to call your friendly neighborhood poison control center for help on this one, since the treatment is so dependent on the ingestion.
Last one, bring us home.
So the second S stands for seizures, and many of the things we mentioned before, like hypoglycemia, sepsis, inborn errors, and trauma can cause seizures. Actively seizing patients should be treated with benzos as first-line therapy. And for these patients, second-line medications include phospheny, phenobarb, Keppra, and valproic acid. Any reversible cause, like hypoglycemia or sodium abnormality, should also be treated promptly. As if that weren't enough things to consider, neonates can have something called pyridoxine-dependent epilepsy, so if your patient has intractable seizures despite multiple AEDs, consider giving pyridoxine or vitamin B6.
Ellen, a great perspective that our jobs are difficult, and especially on your side of the emergency department, we have to, at times, have a systematic and comprehensive approach.
Yeah, I agree. And this is a really, really long list, and there are so many considerations. And I want to reiterate that it's really less important to remember everything on that list and remember that the list exists.
Okay, let's close out the episode with some take-home points. Mnemonics like the MISFITS are vital for retaining essential information and ensuring a thorough approach in high-stress situations. Conditions like cyanotic congenital heart disease and congenital adrenal hyperplasia demand quick recognition and specific treatments such as the use of prostaglandins and hydrocortisone, respectively. It's crucial to identify conditions with subtle presentations but severe implications, such as metabolic disorders and intestinal catastrophes, to provide timely and effective interventions. Lastly, when caring for a critically ill infant, it's important to strike that balance between making decisions briskly and maintaining a comprehensive approach. It's much easier said than done, but repetition in review, mnemonic devices, and visualization can be some tools to help us in these very difficult situations. That'll do it for this episode. Ellen, thanks so much for being back in the studio with us.
Thanks for having me back.